All right. Well, it is 8 a.m. So we will get started with our special medical grand rounds. So today I'm very delighted to have Dr. Victoria Gillet, who, as you all know, is one of our chief medical residents this year. So Dr. Gillet completed her medical school training at the University of Chicago and then completed her residency here in internal medicine at the University of Wisconsin. And she is currently our Trowbridge Endowed Primary Care Chief Resident. As a resident, she was honored with the David Sunday Humanitarian Award and the Lawrence Crocker Award for Outstanding Generalist. And during her residency, she also completed the TEACH pathway and received a Department of Medicine Medical Innovation Grant in order to develop a health equity and advocacy pathway. And impressively, she completed that task and actually was able to see it come to fruition this past year. And the pathway currently has 9 residents in it and will continue after Victoria leaves in the able hands of Dr. Andrea Schnell. So it's really impressive to have created a durable program that will continue beyond one's tenure. So congratulations on that. During her residency, Dr. Gillet has become an active climate justice advocate for Wisconsin. She is a volunteer lead for the Sierra Club's Beyond Coal Wisconsin chapter and team lead for the executive policy with the Wisconsin Health Professionals for Climate Action. Her work in advocacy has been featured in various media outlets, including Milwaukee Public Radio and the Capital Times. She's going to take a much-deserved short break after completing her chief resident year. And in mid-August, she's going to start a new position as a general internist and the first associate program director for primary care at Aurora for the Aurora Internal Medicine Residency in Milwaukee. She, as part of that job, she is going to be creating a new primary care educational program that will promote health equity in a historically medically underserved area. Today, she's going to be talking to us about climate change and health and what the Wisconsin clinician needs to know. So Dr. Gillet, I hand it off to you.
Thanks, Dr. Schnapp. I know it's my CV, but it still feels pretty cool to hear all the best parts read out loud. So as I say, thank you very much for that kind introduction. So I don't have any relevant disclosures, and I'll get right into it. Those of you who know me professionally, and potentially those of you who just read that introduction, may be surprised that my title doesn't include the phrase health equity or advocacy. And it's true that being a health equity advocate and educator at this point is as tied into my professional identity as being a primary care provider is. That's where I spend my academic time and effort. But climate change is the thing that made me into this position. I can't remember a time that I didn't believe that it was happening, but during medical school, I read more and more about the pending health costs and consequences of the climate crisis. And as I read about the disease, disability, and death, and the fact that it would be distributed really inequitably across the world, I eventually thought, it doesn't have to be this way. I'm a physician who cares about health in the broadest sense, and I'm going to use my physician voice to advocate for real, effective, systems-level changes that improve the lives of everyone in my community, regardless of whether they can make it into my office for a visit. But that might not resonate with you. You might be thinking, well, surely those health consequences will be borne by the global south, not my patients in Wisconsin. Or climate change isn't a fight for us clinicians, this is for renewable energy experts and maybe public health professionals. But I'm here today to tell you that climate change has come and will continue to come for Wisconsin, that you will be a more effective clinician if you are prepared for the coming health consequences, and that healthcare professionals have a key role to play in mitigating the most negative impacts that are coming for our patients. So with that in mind, I have 3 goals. First, I hope that by the end of this presentation, you understand what changes are coming to disease epidemiology and adapt your clinical practice accordingly using evidence-based interventions and information. Second, I want you to be able to describe who will be disproportionately affected by the health consequences of climate change and why. And third, I want you to be able to identify how healthcare providers can engage in system-level efforts to mitigate and adapt to climate change. To get you there, here's what I'm going to talk about. First, I'll give a brief primer on how we use climate models to predict health effects. We won't get too deep into physics or wonky policy. I just want to make sure we're all on the same page when we discuss possible scenarios. We'll spend the bulk of our time in number 2, the 4 categories of health impacts that are coming because of increasing global temperatures. For us in Wisconsin, those are increasing heat, worsening air quality, diseases of water, and arthropod-borne infections. Third, we'll discuss which populations of patients will be hardest hit by these changes, why, and some interventions that you can put into place to minimize these disparities. And we'll end with an overview of 3 different levels that you could choose to engage in as a clinical health professional to engage in for mitigation or adaptation efforts. So first, the background. Rising global temperatures have already caused changes to Wisconsin's environment. If you're a Wisconsin lifer, you may have caught yourself saying, back when I was your age, winters were so cold and icy and snowy, I don't know why you can't handle it now. And people might roll their eyes at you, but you'd be right. The average temperature in Wisconsin has increased by 2.5 degrees Fahrenheit just since 1980. And the winter has warmed faster. Over that same time period, the average winter temperature has increased by 4 degrees Fahrenheit. That means decreased spring snow cover, earlier spring thaws, and less ice formation on lakes. There's not anything that we can do about the changes that have already started, but the extent of future warming and the health impacts that will result from that warming do depend strongly on the magnitude of current and future emissions. So that's where this graph comes into play. It's intimidating, I know. I promise it's the most confusing thing that we'll go over today, and I'm going to walk you through it. So on the x-axis, we have time, starting in 1950 out to 2200. The y-axis is increase in average global temperature over pre-industrial baselines. And you can see here we've switched to Celsius from Fahrenheit on the last slide. And you'll also see that there's a red line at 2 degrees Celsius. That's because this is the threshold that the Paris Climate Accord is attempting to stay below in terms of warming above the pre-industrial threshold. The solid black line on the left side of the graph shows temperatures of the recent past, from 1950 to 2013. You can see that it's increased a little bit over time, relatively slowly. And then at 2013, that line spreads out into 3 different colored lines. These colored lines represent something called RCPs. They show how temperature is expected to increase based on how much greenhouse gas pollution will be in the atmosphere by the end of the century. Most climate and health data is projected using these models. Like I said, they're called RCPs, or representative concentration pathways. RCPs with higher numbers after them mean more pollution and therefore more warming over time. One very common scenario to be referenced is the RCP 8.5, and that's the red line here in this graph. Some call this the business as usual model. It's what happens if we just keep burning fossil fuels the way that we've been doing without any consideration for externalities. It's often used as a sort of baseline worst case scenario. Climate health research really commonly models using this RCP 4.5 scenario, which is in blue here on the graph. It's considered an intermediate scenario where, as you can see, emissions reductions are not sufficient to keep the warming below that 2 degrees Celsius threshold, but most animal and plant species are expected to be able to adapt and survive. In the short term, until I or people in this audience retire from practice, all climate projection scenarios have pretty similar outcomes. The slopes are really similar within that time frame, highlighted by the area here in this green box. That's because most greenhouse gas emissions exert their climactic forces on the span of decades, not years or even months. So over the next 10 to 20 years, when we're in practice, we can really use any model without all that dramatic of change in the resulting outcomes. So even though I'll point out an RCP that's being used when it is specifically being used for completeness, we don't have to worry too much about exactly which one is. You'll also notice the large gray error margins around each projection. Climate modeling is an advanced science, but it is not a perfect one. There are many unknowns about the details of how rising temperatures are going to play out. So today I'm sticking to changes for which there is broad scientific consensus that this will happen regardless of what exactly we're going through. The CDC, the US Department of Commerce, the National Climate Assessment, they all agree that the changes I describe are coming, but the extent of the health effects will vary, particularly based on the measures that we put in place in advance to protect our patients from harm. So I promise, no more heavy physics stuff. Now we get to talk about the medicine. We can divide the coming health and disease changes into 4 big buckets: temperature-related illness, air quality impacts, water-related illnesses, and vector-borne diseases. Big picture, all of this is being driven by changes in ambient heat, so let's start there. But first, a poll. Clint, if you could pull up question number 1. So, which of the following clinical signs or symptoms are required for a diagnosis of heat stroke? Hypotension, central nervous system dysfunction, pulmonary edema, rhabdomyolysis, or disseminated intravascular coagulation? I'll give us about a minute. Okay, I think that's probably good for time. Clint, if you could show us the results. Awesome. Yeah, you guys are right. It's central nervous system dysfunction. All of the rest of them, hypertension to DIC, can be present, but they are not required for the diagnosis. All right, you can close that out. Oops. We're talking about heat stroke to remind us that extreme heat has health consequences, and climate change will lead to days with more extreme heat in Wisconsin. So these are maps that are put together by Wisconsin's own Nelson Institute for Environmental Research to illustrate this point. We can see the state of Wisconsin twice, and Dane County is pointed out here in red. That key on the right shows us that the darker yellow an area is, the more frequently that area experiences a given condition. For this first set of maps, that condition is the distribution of days per year where the maximum temperature is over 100 degrees Fahrenheit. The map on the left shows the recent past, up until 2010. We can see that that map doesn't have any yellow on it at all. That means on average, Wisconsin experienced literally 0 days over 100 degrees Fahrenheit over that time period. The map on the right shows how the Nelson Institute projects this will be different around about 2050 under that RCP 4.5 scenario, or the intermediate one. Most of the map is now yellow, meaning those counties can all expect multiple days over 100 degrees each year. For the second set of maps, we're instead evaluating elevated nighttime temperatures, over 70 degrees Fahrenheit. Nighttime temperatures are significant contributors to heat-related mortality because population and infrastructure doesn't have the ability to recover and cool down from really hot temperatures during the day. Again, the recent past is on the left, and the projection for 2050 is on the right. We see here that historically, southern Wisconsin experienced about a week's worth of these elevated temperatures per year, while northern Wisconsin had essentially none. But in 2050, that orange color in Dane County means that we can expect up to 20 hot nights per year in our city. Now, I said that extreme heat is dangerous, and these numbers and colors might not seem all that extreme. But there is no threshold at which point temperatures are labeled as extreme for health consequences. That's because the danger of elevated temperatures depends dramatically on things like the heat wave happen early in the summer or later when people understand how to respond to elevated temperatures. It also depends significantly on the built environment. Does the population have easy access to air-conditioned spaces? Broad penetration of air conditioning in hot places like Arizona means that people are easily able to escape from the hot temperatures already there. So their morbidity and mortality is actually pretty low, despite the fact that it's hot. For this reason, northern Midwestern communities like ours that historically have not experienced high temperatures will be particularly unprepared for increasing temperatures and are projected to have the largest increase in extreme temperature-related deaths compared to the rest of the United States. We've seen the consequences of this lack of preparedness in the past. So for a baseline, Wisconsin experiences about 15 deaths per year attributable to extreme heat. One single heat wave in the Midwest in 1995 caused over 100 deaths in 1 week. That was just in Milwaukee, and temperatures were over 100 degrees for only 3 days. Notably, only about half of the deaths in heat waves like these are attributable to direct heat-related illnesses like heat stroke. The rest are caused by exacerbations of underlying illnesses like heart attacks in patients with coronary artery disease. Our aging internal medicine population will be particularly susceptible to that cause of elevated mortality. So elevated temperatures are dangerous in and of themselves, but they're also going to drive a variety of other negative health impacts. One of them is poor air quality. I'll propose a hypothetical patient. RJ is a 37-year-old female with asthma who you're seeing for an ER follow-up visit for her asthma exacerbation. You first met her when she transitioned from pediatric care, and at that point, her asthma was under very good control with a daily ICS-LABA and some occasional albuterol, and she never really had flares, maybe one a year. She never had ER visits. Now she feels like her flares are both more frequent and they're more severe. And this ER visit that you're seeing her for happened in October. She would never even have had exacerbations back then, in the past. She feels like she's doing something wrong, and she says, "Doc, what's changed?" For RJ, the answer very well might be pollen. Elevated pollen levels are a significant cause of morbidity, especially for asthma. They're correlated with worsened pulmonary function tests and an increased frequency of ER visits for exacerbations. I adapted this schematic from the Allergy Associates of La Crosse to review the various allergen seasons for a given year here in Wisconsin. We've got the 4 main allergen producers: trees, grasses, weeds, and mold. The dark green bars show the extent of their allergenic season. Trees, for example, in the first line, put out pollen from March until June. The light green bars represent their peak season, which for trees centers around late April. These existing ranges are already much longer than they were in the past. The ragweed's growing season in particular has increased by 12 days since 1995 here in Dane County. And seasons will continue to lengthen. Trees will bloom earlier, grasses will be able to flower for longer, and weeds are expected to be able to both start earlier and end later. But seasons won't only last longer, they will be more aggressive. Experimental studies have shown that increasing ambient carbon dioxide levels directly stimulates ragweed and grass pollen production. A group out of Harvard used this data to project the number of grass pollen particles per year here under the RCP 8.5 scenario. Each bar is a 20-year period. They start with 2000 as the baseline and project forward as far as 2080. The y-axis is increase in grass pollen particle production relative to 2000 levels, that bar in green. By 2020, we're already about 20% above that baseline from 2000. By 2060, grasses will be pumping out literally double the amount of pollen per year from that 2000 baseline. Similar data have been presented also for ragweed pollen. Even more disturbing, it has been shown that increasing ambient carbon dioxide levels directly increases the quantity of ragweed pollen's major allergenic antigen, a protein called AMB-A1. So that means that each pollen particle that we come into contact with will be more allergenic. But our patients won't only be grappling with more pollen, but also with more ground level ozone. But Victoria, you say, the ozone level is good. Didn't we do a bunch of work to make sure that it was up there in the atmosphere? And yes, it is good when it's in the stratosphere. In the stratosphere, ozone absorbs UVB radiation before it can make it down to my gentle melanocytes here on the ground. But at the ground level, where we walk and breathe, ozone is a toxic gas that produces airway and systemic oxidative damage and inflammation when inhaled. So much so that its exposure to ozone has been directly linked to increased asthma incidence and even all-cause mortality. Ground level ozone forms when heat and sunlight catalyze reaction between various pollutants. So that means that more heat means more catalyzing, means more ground level ozone. And because of complex meteorologic modeling, the Midwest is projected to be particularly hard hit by increases in ground level ozone with climate change. Here are some maps to illustrate that. The left map shows a projected change in ozone levels across the US in 2030 compared to a baseline in 2000. Darker orange means a greater increase. The right-sided map shows increases in ozone-related deaths over the same time frame. In both maps, you can see that Wisconsin is particularly hard hit, especially compared to the rest of the country. Ozone is projected to continue to increase over the course of the century and will likely result in an additional to 200, potentially even 500 premature deaths in the Midwest per year by 2050. So overall, we can expect air quality to worsen, especially in the spring and the summer, due to increased volumes of more allergenic pollen and increased ground level ozone. This will mean worsening cardiopulmonary disease control for our patients like RJ. So next up, we'll talk about water-related illnesses. Annual precipitation isn't actually expected to change all that much for Wisconsin, but we can expect more extremes, and that means more flooding, like this one here in Fort Atkinson. River flooding can flood surface streets and low-lying areas. The immediate consequences of this flooding, things like accident and injury, will mostly be borne by our emergency room physician colleagues. But flooding has many additional health consequences, including increases in waterborne disease outbreaks. Heavy precipitation leads to stormwater discharge of contaminants, particularly GI pathogens like norovirus. In the Midwest, we already know that contamination events occur typically when rainfall exceeds a threshold of about 2 inches per day. Precipitation events are known to cause waterborne diarrheal outbreaks in northern Wisconsin because the vast majority of residents in these counties depend on minimally treated or untreated groundwater for their day-to-day water needs. Those 2-inch rains are going to become more frequent across the state. This is another set of maps from the Nelson Institute, and we can see that the key on the right side shows that this time darker blue means more days per decade of those greater than 2-inch rain events. We've got Dane County again tagged in red, and the left side map shows historical trends again. The upper counties of the state historically experience about 3 heavy rain events per decade. That's pretty low, which is good because, like I said, they are the most susceptible to groundwater contamination after these events. Dane County gets about 1 event per year in the recent past. The right-sided map shows projected rainfall distribution around 2050, like in those previous maps, under the RCP 4.5 scenario. Essentially, every county in Wisconsin will experience a 2-inch rain event yearly, including those that use that untreated groundwater. And most counties will experience those big rain events more frequently than that. Extreme precipitation events also increase nutrient loading into waterways. That is to say, home and industrial fertilizer gets swept from the locations where they're placed on the ground and into our lakes and rivers. Nutrient-dense waters, especially in combination with elevated water temperatures, facilitates blooming of cyanobacteria. That's the so-called blue-green algae that we all know in Madison and love to hate. And it's actually present in our lakes today, if you've read some of the news. This is a photo of a bloom on Lake Mendota by Eagle Heights. It's obviously ugly, but exposure to it and the toxins that the cyanobacteria produce also cause illnesses like eye irritation, skin irritation, respiratory and gastrointestinal illnesses, as well as potentially liver and kidney damage. That's in humans. It can also accumulate in fish pretty easily at levels that are well above the WHO recommended tolerable daily intake value. And this exposes patients to risk of toxic exposure, even if they don't enter the water, just by eating food that someone else has procured. Our last section is on changes in vector-borne infectious diseases. Big disclosure here that I am not an infectious disease doctor, but if you want an ID doctor's expert explanation of this exact topic, please go back and watch Dr. Mackey's grand rounds on emerging infectious diseases and climate change from last year. And Dr. Mackey, if you're in the audience, please forgive me for some maybe generalizations in this category. With that out of the way, we'll do our second poll. Clint, if you could pull up question number 2. So this one is a choose all that apply question. There may be more than one correct answer. So there are 3 main genera of disease-causing mosquitoes in the U.S. Which one or ones currently have Madison in their range? Like I said, multiple choice here. The Anopheles, the Aedes, and specifically the Aegypti and albopictus species, because there are lots of other Aedes that don't transmit many infections, and then also the Culex mosquitoes. And give us all some time. I feel like these choose multiple answers can be a little bit more time consuming. Definitely don't prefer to see these things when I'm taking standardized tests to maintain accreditation. All right, just a couple more seconds, then I'll close out. All right, Clint, I think that's good. Can you show us the results? All right, you guys pretty good, not perfect. So for this, I'm actually going to give a shout out to Orkin, the pest control experts, for having the best US mosquito map distribution to show us the answer here. So this is what we've got. So we've got the Culex range outlined in purple, the Anopheles range outlined in blue, and the Aedes range outlined in red with that sort of orange fill-in color. And you can see that the Culex mosquitoes and the Anopheles mosquitoes have the entire United States in their range, including Wisconsin, whereas the disease-bearing Aedes mosquitoes maybe make it up a tiny bit in Wisconsin, but not quite to Dane County. And for some reason, Denver, I don't know why, don't ask me. All right, so we can close that out. So I'll talk about each of these genera in turn. I'll start with the Anopheles because it's well known as the vector for malaria. Most folks associate malaria with tropical climates, but that's actually not necessary. Malaria used to be endemic in the US and was a diagnosis in Wisconsin as recently as 1850. It was eliminated by a very successful campaign by the precursor to the CDC, and climate change will actually have very little impact on whether or not it becomes reintroduced to the US. The Aedes mosquitoes transmit yellow fever, dengue, chikungunya, and Zika. Their range can be expected to expand northward as temperatures and rainfall levels change. Thankfully for us, most of the diseases that they carry are less transmissible at the temperatures that will be present in Wisconsin. That means we shouldn't expect dengue to become endemic in Wisconsin, thankfully. We should, however, expect them to become endemic in the southern parts of the United States. And that means we need to consider these diagnoses in patients with fever who are coming back from their overwintering homes in Arizona and in Florida. And finally, the Culex mosquitoes are vectors for viral encephalitides like West Nile, St. Louis, and Western equine encephalitis. These mosquitoes are already everywhere in Wisconsin, but warming temperatures will lead to longer mosquito seasons. And as a consequence, the CDC is projecting hundreds of additional cases of West Nile virus in the Midwest per year by the end of the century. If we're going to talk about Wisconsin arthropods, we're obviously also going to talk about ticks. Climate change is expected to lead to an increased incidence of Lyme disease in Wisconsin, and it's hard to really understand why without a review of the Ixodes life cycle. First thing, it's long. Visual life cycles like this one usually present it as lasting 2 years. However, that requires ticks to efficiently find blood meals at 3 stages in development: after they hatch into larvae, after they molt into nymphs, and then finally again after they molt into adults. Only then can the females mate and lay eggs. It's not uncommon at more northern latitudes like ours for ticks at a given stage to fail to find a blood meal at a given stage in development before they have to go dormant for the winter. And this can delay maturation by up to 2 years. Earlier springs and later falls make it easier for ticks to consistently meet their nutritional needs, so that means that they can reproduce as soon as possible. And while heat can accelerate that life cycle, cold can end it. Overwintering ticks die when they're exposed to sub-freezing temperatures for prolonged periods of time over the winter. That helps keep their numbers in check in northern latitudes like ours. The coming warmer winters will likely mean more ticks ready to go come spring. So those are the health consequences that are coming to Wisconsin because of climate change, but they will not be borne equally across Wisconsin's population. Certain groups have been identified as populations of concern. That is to say, those who are particularly vulnerable to the negative health impacts that are coming because of medical comorbidities, behaviors, or structural discrimination. The consequences of people who have underlying medical comorbidities depend on the exact comorbidities. For example, certain medications like anticholinergics that decrease the sweat response make patients more susceptible to heat illnesses. And anyone dependent on medications or medical supplies risk care disruption during natural disasters. Local severe weather events can obviously destroy things directly, but distant events can have very negative consequences as well, like medication shortages when supply chains are disrupted or even destroyed, like they were with Puerto Rico and Hurricane Maria. These patients need individualized education and action plans. How do they prevent exacerbations of their particular diseases? What do they do if their medication supplies aren't available? Can they go without? Or if they take insulin, do they need to find alternatives? Anyone who spends more time outside will be more exposed to heat, pollution, allergies, and arthropod vectors. This includes outdoor workers like farmers and members of the military, as well as people experiencing homelessness. To minimize negative impacts for these patients, they need access to cooling center on hot days, respiratory protection when air quality is poor, and highly effective insect repellent. Rural populations, like I said before, are more likely to use untreated or minimally treated groundwater for their day-to-day needs and are therefore more susceptible to water contamination. Emergency response to extreme precipitation events is also more challenging for this population due to our centralized healthcare infrastructure and deteriorating transportation infrastructure. More robust water treatment in rural areas can protect them from contamination, and they also benefit from robust emergency response protocols. Tribes and indigenous communities in the Midwest have been among the first and worst hit when it comes to feeling the effects of climate change. It can impact their culture, sovereignty, health, economies, and ways of life. There are 12 tribal nations that have their reservation, trust, or ceded lands within the border of the state of Wisconsin, and the borders around those lands are quite strict. As the climate changes, various species utilized by tribes for nutritional, medicinal, and other purposes are declining and may shift outside of those treaty boundaries entirely. Plans made to mitigate risk must be made in close collaboration with tribal leadership. Finally, urban people of color. Lower income and more densely populated urban areas are more susceptible to something called the urban heat island effect. That's when asphalt and other infrastructure absorbs the sunlight and heat of the day, keeps it there overnight, and potentially even into the next day. This can lead to inner city temperatures that are up to 20 degrees higher than the surrounding green spaces. Households in these lower income, more densely populated urban areas are also experiencing a higher degree of energy burden. That means that they pay a higher percentage of their income just to keep the power on, often leading to an inability to choose between paying for their electricity and paying for food or health care. Because of racist home lending restrictions in the cities in the mid-1900s, known as redlining, as well as continued structural discrimination, these densely populated urban areas are also more likely to be Latinx and are much, much more likely to be Black. This means that Black Milwaukee residents in particular will experience higher levels of ambient heat, but will be less likely to be able to pay for the air conditioning to escape it. To minimize the risk of heat illness for these populations, they need access to air-conditioned spaces and improved energy efficiency for their homes to be able to pay for their energy needs. So we've gone over the what and the who of climate change and health in Wisconsin. Now we get to talk about some more hopeful things. How can we, as healthcare providers, be a part of solutions to protect our patients from these negative harms? But before we start, I've got one final poll question. Clint, if you can pull that one up. So for this last question, there's a statement, actually. Healthcare providers have a responsibility to bring the health effects of climate change to the attention of the public. How do you feel about that sentence? Do you strongly agree, feel neutral, disagree, or strongly disagree? Give folks some time. Oh, I should say that these are anonymous, so I'm not going to be going back and checking if you agree with me later, in case that makes you nervous to click on the buttons. All right, give us a couple more seconds. All right, Clint, I think that's good. All right, so we've got a good complement of strongly agree and agree here. And I want to show you how this compares to a previous study, because I actually pulled this from a survey of the American Medical Association back in 2014, because I was really curious to see how we compared. So you can see here in the original survey, 70% of respondents said that they agreed or strongly agreed with the statement that physicians, in this case, have a responsibility to bring the health effects of climate change to the attention of the public. And we're actually feel that even more strongly. So we're at, what, 84%, which I mean, obviously I feel good about. But I think we can close that out. I was honestly surprised by the result of this study, and maybe even a little bit more surprised by the result of our study, because if you try to suggest on like Twitter that physicians have any kind of professional responsibility to engage in public education or advocacy, you can get shut down really hard. But this and other polls suggest that there's broad acknowledgement of the importance of patient and community-based education on climate and health. And even if you think that this work isn't a professional responsibility, you still might feel called to do something as an individual. And I'd like to propose 3 different ways that you can use your role as a clinician to mitigate these oncoming risks for our health. They are clinical practice, organizational advocacy, and political activism. In terms of clinical practice, you should be prepared for the changing epidemiology of diagnoses you encounter in practice. You've already got a leg up by having come to this grand rounds. For example, know how to recognize and treat heat stroke and other diseases of thermal exposure. Consider a therapy escalation in patients with allergenic asthma who have worsening control. Be aware of toxic algae blooms in your community and ask patients about exposures when they present with unexplained illnesses. And have a higher index of suspicion for West Nile virus and other encephalitides in patients who present with altered mental status. When you're better educated, you can serve as a better resource for your patients. So there are certain things you can do for patient education. For example, counsel patients about the prevention of heat injuries. Meta-analyses project that clinicians doing so actually decreases mortality during heat waves. OSHA, not that we love OSHA, but they actually have an excellent app for this that you should recommend to anyone who regularly works out of doors or people who are vulnerable before heat waves. So they just download the app and either attach it to GPS or put in their location, and then they get to see this, right? So they see the temperature, specifically the heat index, and how risky that temperature is. There's possible precautions if risk is elevated based on the temperature, and they can even check to see if symptoms they're experiencing down below at that bottom are related to heat exposure. So that's one great resource. Another thing that you can do is teach your patients how to monitor air quality, especially if they have pulmonary or cardiovascular disease that puts them at high risk. airnow.gov is an excellent site for this for the US. For example, you might tell them how to go to airnow.gov, they see that it looks like this. And if the air quality is orange for the day, that's unhealthy for sensitive groups, that they don't go outside when it's the most hot and they don't exert and do any really high strenuous activity. But you might say, look, if it's purple, if it's in that very unhealthy range, you don't go outside at all. If you really have to, you wear an N95. You should also know whether or not your patients use well water or otherwise untreated groundwater for their day-to-day water needs, and then instruct them to boil or disinfect their cooking water after heavy rainfall. And last, remind patients to use effective mosquito and tick repellent, not citronella candles, if they're at any significant risk of vector-borne diseases. Permethrin-impregnated clothing and DEET are classic sort of baselines for effective protection, but there's a new product on the market, picaridin, that you can recommend to patients who are wary about DEET in particular. Those are really the 3 effective, reliable ways to prevent vector-borne diseases, that plus mosquito nets. So knowing how to optimally care for our patients will help us be resilient to the changing landscape, but some of you might be activated to use your physician voice to engage on climate change mitigation and adaptation efforts in a systemic way. And organizational change is a great place to start because depending on who's counting, the healthcare industry accounts for 8.5 to 10% of all greenhouse gas emissions in the United States. So there's a lot of room to innovate and decrease those emissions and make them go away. You can, for example, encourage the facilities where you work to lead by example and engage in sustainable practices. This can be an excellent opportunity for QI projects for medical students and other learners. And we can actually look right here in Wisconsin at Gunderson Health Systems for an aspirational goal of what sustainable healthcare can look like. They were the first health system in the United States to offset 100% of their fossil fuel energy use with local energy projects. That included things like methane biodigesters and local wind farms. They've also reduced food, pharmaceutical, and hazardous waste use by 75%, and they report that they save $3.7 million per year through these efforts. But you might be hesitant to engage with your employer, which is understandable. So instead, you could push your professional associations to explore and address the issue of climate change and the role the healthcare sector has in adaptation and mitigation. The American College of Physicians and the American Thoracic Society both have policy statements on climate change and health. Does your professional society have one? What are they doing to actively engage in changing healthcare for the better? Organizational advocacy is great, but maybe you think the scope of this problem deserves a bigger scope of your involvement. Then it might be time for you to take aim at governmental policy. For those of you who haven't forayed into public action, it can be pretty daunting. I've publicly labeled myself as an environmental advocate for the past 3 years, and I'm still terrified by the idea of sitting down across the table from my legislators to talk about this. But I'm here to tell you that your medical expertise makes you more than qualified to throw your hat into this arena if you're interested. And here are some big reasons why. First, you are trusted. Every year since 2001, Gallup has asked Americans about the honesty and ethics of various professions. For 19 out of the past 19 years, nurses are number 1. Physicians are almost always number 2, and pharmacists are consistently well regarded, at least in the top half. The public just trusts healthcare professionals. Second, your message matters. The public, by and large, does not consider climate change a health issue. They think of it in terms of polar bears and rainforests. But this is a problem because this messaging framework makes people feel more hopeful and other positive emotions and makes them more willing to engage with the issue. Third, you are not alone, nor should you be. For all that political advocacy is a key part of my professional identity, many physicians I respect refuse to become politically active because they don't have education or training in political science. But the great news is you don't need to have that training because there are innumerable organizations that have the training, the expertise, the programs, and they are just desperate for your healthcare voice. So here are some examples of ways that you could get involved if you are so inclined. If you want to help Wisconsin residents get more energy efficient homes, you could partner with Citizen Action of Wisconsin. If you want to preserve water quality in our local lakes and rivers, you can volunteer with the Clean Lakes Alliance. If you're excited about stopping carbon pollution at its source, you can get active with 350 Madison. And if you're just a health professional who wants to work with other health professionals on any or all of the above, you should please join me at the Wisconsin Health Professionals for Climate Action. So that's Wisconsin climate and health in a nutshell, but it's a big nutshell. So I just want to review what we talked about so far and make sure that everything makes sense. So in Wisconsin, climate change will cause hotter days, which will in turn cause increased mortality. Our air quality will worsen, leading to worsening cardiopulmonary disease control. More extreme rainfall events will contaminate waterways with diarrheal illnesses and cyanobacterial toxins. And Wisconsin will become an even more suitable habitat for disease-bearing mosquitoes and ticks. Patients with relevant medical comorbidities will be particularly vulnerable to these negative health effects. Those who spend more time out of doors will be exposed to poor air quality and heat and vector-borne diseases. Rural patients will suffer from contaminated groundwater and be cut off from emergency services when extreme weather events threaten their health and safety. Tribal populations risk being cut off from their medicinal, economic, nutritional, and cultural environmental resources. And urban people of color, particularly Black residents of Milwaukee, will suffer most from urban heat and an inability to pay for the electricity needed to survive it. But there is much that we can do as clinical health professionals. We can be prepared for the changing epidemiology of diagnoses we encounter in practice. We can push our workplaces and professional organizations to engage in more sustainable behaviors. And we can use our voices as trusted healthcare professionals to advocate for public policies that mitigate greenhouse gas emissions and help our vulnerable patients adapt to the coming threats to their health. So as you sort of saw there, I'm going to end with a quote. In the middle of working on this presentation, I had a letter to the editor published in the Cap Times where I expressed some frustration that our legislators removed support for home energy efficiency programs from the state budget. 2 days later, I walked into clinic and introduced myself to a new patient for the very first time. And this is what she said. "Did you write that letter in the paper? I was so happy to see it. I wish more doctors advocated for us. Thank you for doing that." I'll be thinking back to this quote anytime someone tells me that this work is not in my lane. So that's what I have for you today. I want to give some big thank yous to Dr. Jeremy Smith and this first group for helping me prepare for my very first grand rounds, to Cassie Steiner and the second group for being the best group of climate activism teammates I could have to keep the work engaging and usually fun. My three co-chiefs, Dr. Banaszak, Donahue, and Fell, for being the reason that I survived this past chief year. And Dr. Hannah Bell, Abby Mapes, Dr. Andrea Schnell, and the DOM education group for being the reason that I could make advocacy a key part of my professional identity over the past year. So I've got some time for questions. You'll see a QR code there that takes you to a area that has a bunch of links for resources that were brought up, like that airno.gov and the app and some other things if you want to learn more. If you want to see all of my sources, or if you have any other questions, you can email me, though since I'm moving to Milwaukee, that email only works for a couple of weeks, so reluctantly, if you really want to, you can contact me on Twitter. Not that I love social media. So, yeah.
Great. Well, thank you very much. And I also appreciate the shout out for the American Thoracic Society.
I thought you would.
We've done a lot of work on climate change and advocating for against air pollution, and so appreciate it. So there's a before we get to the questions, I just wanted to remind our faculty and attendees about the UW policy for advocacy. So when you are contacting politicians, etc., please be aware of what the UW policy is. We are not permitted to lobby, ask for signatures for petitions, etc., on university time, or using your university email. So make sure you are aware of the policy and adhere to it.
Great point. Yeah, any system has their own sort of rules and expectations for how to engage in that kind of work. So
yes, and we're a state, we're state employees of UW Health, so we have to be very cognizant and careful about that. So first question from Shobi Cheda. What are your thoughts about the extent to which embracing a vegetarian or vegan diet helps climate change?
Yeah, Dr. Cheda, that's a great question. So I think there are two parts to that, right? There's personal change and how much do you suggest that your patients engage in that kind of change? And I personally take the approach of, I know some climate activist physicians who really encourage their patients to shift to those kinds of diets because they are quite effective. When we look at lists, so like Drawdown is this great resource for trying to get a sense of exactly what kind of interventions are the most impactful for reducing greenhouse gas emissions, and shifting to a more plant-based diet is really, really high up on there from an individual change perspective. But I am pretty careful about only talking to patients about things that I think are specifically relevant to their health. And if they were to ask me about this, I would say like, yes, and also climate. The other part of that is that when I started doing this work, I was really invested in engaging in personal activities, right? So, like I don't drive, I eat a mostly vegetarian diet. I do a lot of personal things that decrease my carbon footprint, but carbon footprint is not really the point, right? The point is to create systems level changes that decrease burning of fossil fuels and other sort of like big picture problems that are systemic. So I think like, yes, on a personal level, it's probably good. But also if going vegetarian or ditching your car or something like that means that you're less able to fight for system level change, it's probably not really worth it.
Great. And my understanding, I actually think it is complicated whether vegetarian or vegan diets have as much impact on climate change or decrease your carbon footprint than initially appreciated.
Yeah, I think the science is still pretty solid. Pretty much every protein source, in particular beef. If you're going to do something, you cut out factory farmed beef, 100%, like that is the primary agricultural problem driving increased emissions.
Yeah. Question from Betsy Trowbridge. What will need to happen for climate change to no longer be political?
Oh, Betsy. I I don't have an answer to that. I think that there are lots of answers that people have said in the past, like, oh, when it's actually happening, or oh, when we see the consequences. And I would argue that I see the consequences, right? Like the heat this weekend, not normal. Cyanobacterial blooms the first weekend in June, not super normal, right? This stuff is happening and it's still political. There are lots of things in healthcare that shouldn't be political that are. So never. The people who have levers, who think about how to push things in a bipartisan way, really try to push for things that have broad impacts. And that's part of the point, actually, of healthcare messaging, is that it does have broader engagement as opposed to just, polar bears or whatever else. And so some of that healthcare terminology really does get through in a less political way because most people agree that people should be healthy.
A question from Samir Mather: has UW Health been responsive to any of the climate efficiency initiatives that are modeled by Gunderson?
So UW Health is, to its credit, seen as a leader in sustainability initiatives, but most of that is in regards to waste management and like anesthetic gases and things like that. We have really not done very much as an institution when it comes to sort of transitioning to renewable energy sources and things like that. And, I said maybe people don't want to engage with their employers. That's really the position that I feel like I'm in right now. That's not where I feel excited to engage. But there are a variety of people, in particular with the Wisconsin Health Professionals for Climate Action. We have a whole climate smart healthcare group that really engages in that kind of advocacy work.
What are your thoughts about advocating for bike-friendly cities?
I love that. That's a big part of what I do. Some of my systems level work is on, like I said, shutting down coal plants, but also I am a cyclist myself, and I am closely correlated with our transportation teams, right? Like not expanding highways and putting in more bike lanes and also more effective bus lanes and other sort of public transportation infrastructure all decreases transportation emissions, which are a huge problem, right? Transportation emissions, sort of depending on how you carve things up, is potentially the biggest contributor to climate change overall. And actually, transportation within healthcare is the biggest proportion of healthcare-related emissions. So always in favor of biking and in favor of safe biking, very much so.
I have a question. So you talked about a number of things, a number of diseases or syndromes that are anticipated to be increased with climate change. Are there things that we anticipate to decrease with climate change?
Yeah, so the easiest answer there is diseases of cold thermal exposure. Right, not surprisingly, in the Midwest in particular, right, the likelihood that we have those days like we had a couple of years ago where 45 degrees below zero in the long term will decrease significantly. So I think that's the biggest, easiest one. Trying to think about other things that might decrease really have to do with mitigation efforts, right? So if we're really decreasing greenhouse gas emissions, that decreases particle pollution, which I don't know if you saw, there was this correlation between particle pollution and actually susceptibility to a positive COVID test or negative outcomes for COVID. So there are certain actually dramatic health improvements that come with shifting to sustainable practices. And so we can see immediate health benefits from engaging in transition to good things. But that's much more like a big picture policy level and a little bit less, like us as doing clinical work.
And is learning about the health ramifications of climate change part of medical student curriculum, and how is that incorporated?
At UW it is. So we have a really excellent MD here at UW called Jonathan Patz. He was a part of the IPCC, the International Panel on Climate Change. I'm blanking. So he doesn't practice medicine, has an MD, really, really prestigious in that realm, and you could interact with him with Wisconsin Health Professionals for Climate Action. But he teaches a course on climate and health for the medical school. And that is an elective. I think most climate and health education is an elective at the medical school level right now. But there is a general movement, and a lot of these other sort of like surveys, like the one that I saw from the AMA, suggest that people really want more climate and health education, both trainees and also people wanting CME credits for stuff like this. So I think there's a shift towards more, but it's not currently a standard in education.
And then, so while it's not directly impacting Wisconsin, worldwide, one of the large source of pollution is indoor pollution, or a major source of health effects is indoor pollution and stoves and indoor burning.
Yeah.
Can you address that? What's your
Yeah, I will say I'm not a global health expert. I have really intentionally shifted to being a local person as a primary care provider and being invested in my personal communities. And so I'll sort of challenge the first thing that you said, which is that it's not present here. And there's actually more and more data that shows that people with gas burning stoves are exposed to things like nitrous oxide and other toxic chemicals, actually things that can produce ozone potentially, and that being exposed to those gas burning stoves makes you more likely to have respiratory illnesses. So we do see it here, though obviously not to the same extent of wood burning internal stoves in other countries. And I do know that there are initiatives, in particular, sort of like in sub-Saharan Africa, to help people shift with using, like different kinds of solar models and other renewable opportunities for less polluting. Because indoor air pollution is, as we saw if you went to the grand rounds a couple of months ago, is one of the driving causes of cardiopulmonary disease in sort of pre-industrial nations. So totally agree with that.
Yeah. What can we do better in our residency program?
Oh, I don't know. It's complicated. Like I said, I keep this work pretty separate from my clinical work, more or less, because of the fact that it's a little bit political and some people don't see it as clinically relevant. But I think any of the stuff that I presented here today is pretty obviously clinically relevant. We will continue, hopefully, to have a talk like this one every year through the Health Equity and Advocacy intern lecture series. I actually wanted to give a shout out to anyone who's interested in advocacy as a broader topic and wants to talk to residents about whether you engage in that and what that means for you, or health equity as a broader topic, to reach out to Abigail Mapes. She's listed at the bottom of that thank you slide. She's going to be the coordinator for the health equity and advocacy curriculum as we go forward after I leave. So anyone who is excited about this kind of work or any other equity-related work, we'd love to have you engaged and bring in more and more faculty and sort of get whatever your excitement or expertise is related to this kind of stuff involved in teaching residents. So I think it's all culture, right? Do you want to engage, or is it seen as a thing that's too scary? And I'm hoping that people, generally speaking, now start to see as a thing that's worth engaging in.
And finally, Betsy Trowbridge would like to say something.
Okay.
No, I just want to be unmuted at the very end, not now.
Oh.
Okay.
A preview of something dramatic.
Final question is recycling. Is it all that it's cracked up to be?
No.
Okay.
Yeah, I mean, I try to avoid taking things into my home that I recycle, that have to be recycled, as much as possible. And when I do take them in, I don't care that much if they end up in the trash. Right? Plastic recycling almost never happens. You may have heard about all that stuff in China and different countries that are refusing to take our recycling waste because it's not actually recyclable. Don't worry about it too much. It's not that big of a deal. Put your energy elsewhere.
Okay. All right, Betsy. Okay.
Sorry, I think there's a little misunderstanding of what the end was. So
Yeah. Okay, so I just want to say I'm super proud of you. Great grand rounds, and Milwaukee is getting a fantastic doctor.
Thanks, Betsy.
Awesome. Okay. Great. Well, thank you. I will echo what Betsy said and very much appreciate having a wonderful grand rounds on a important topic and showing us how climate change really does have important health implications and giving us a pathway to move forward in this.
Yeah.
So thank you. Thank you.
Really appreciate it.
And
Thanks, everybody.
take care, everyone.